Good evening, everyone. Today, I'll be presenting a recent and much-anticipated clinical trial, the UK-ROX Randomized Clinical Trial, published in Journal of the American Medical Association in June 2025. This study explores a very important and practical question. Should we be more conservative with oxygen therapy in ventilated ICU patients? I invite you to walk with me through the key findings, strengths, and implications of this landmark trial. Oxygen is perhaps the most frequently administered drug in critical care. Yet, unlike most drugs, we often overlook the need to dose it carefully. Too little oxygen leads to hypoxia, organ dysfunction, and death. But too much can be just as dangerous, causing oxidative stress, vasoconstriction, inflammation, and lung toxicity. Historically, ICUs have erred on the side of giving more oxygen, fearing hypoxia. But emerging evidence suggests that over-oxygenation may be doing more harm than good. This trial asks, can we safely dial back? The clinical dilemma. This brings us to a common dilemma faced in the ICU every day. What oxygen saturation target is just right? A conservative strategy aims to minimize oxygen-induced harm. A liberal approach aims to avoid any chance of hypoxia. Striking that balance, not too high, not too low, is what this trial explores. Study objective. The UK-ROX trial set out to answer a simple but powerful question. Can targeting a lower SpO₂ range of 88 to 92% reduce 90-day mortality in mechanically ventilated patients, compared to usual oxygen therapy with no defined upper limit? Aiming to resolve this tension between safety and necessity, the trial tested conservative oxygen therapy in a large real-world ICU population. Study design at a glance. This was a large, pragmatic, multi-center randomized controlled trial conducted across 97 adult ICUs in the UK between May 2021 and November 2024. Over 16,500 critically ill patients on invasive ventilation were enrolled. The trial had a robust design, with patients followed up until early 2025. They were randomized to receive either conservative oxygen therapy or usual care. Patient flow and randomization. Out of over 52,000 patients screened, about 38,000 were eligible and 16,500 were randomized. 8,258 were assigned to conservative oxygen therapy, 8,242 to usual care. Importantly, data on the primary outcome was available for 99.4%, ensuring high-quality, reliable results. Baseline characteristics. The median patient age was 60 years, with about 38% being female. Sepsis was the most common diagnosis, present in 1/3 of patients. There were also smaller groups with hypoxic brain injury and other neurological conditions. Notably, around 7% had confirmed or suspected COVID-19. This was a diverse and representative ICU population. Inclusion and exclusion criteria. To be included, patients had to be adults more than or equal to 18 years, mechanically ventilated, receiving supplemental oxygen, enrolled within 12 hours of meeting eligibility. They were excluded if they were on ECMO, had already been enrolled earlier, or if the treating clinician felt it wasn't appropriate, ensuring ethical flexibility. Randomization and stratification. Randomization was done centrally, in a 1-to-1 ratio. It was stratified by site and by primary diagnosis, including sepsis, HIE, brain injury, or other causes. The intervention was not blinded, which is a limitation, but understandable given the nature of oxygen administration. Patients in the conservative group were managed with a clear target: SpO₂ of 90% with acceptable range between 88 to 92%. The FiO₂ was kept as low as possible to stay within that range. Alarm limits were set at 88 and 92%. If the FiO₂ reached room air, the upper alarm could be disabled. This approach aimed to minimize unnecessary oxygen exposure while avoiding hypoxia. In contrast, the usual care group had no strict SpO₂ target. Oxygen was adjusted at the clinician's discretion, without upper alarm limits. This represents the standard practice in many ICUs, often aiming for SpO₂ around 94 to 96%. Primary outcome. The primary outcome was 90-day mortality. Conservative group, 35.4% mortality. Usual care group, 34.9% mortality. The difference was not statistically significant. P-value is 0.28. Odds ratio, 1.04. The survival curves for both groups were virtually identical. Secondary outcomes. There were no meaningful differences in ICU length of stay, hospital length of stay, days alive and free from organ support. However, serious adverse events were slightly higher in the conservative group, 58 versus 29 events, though still rare overall. Subgroup findings. Subgroup analysis showed no significant differences across key categories. Sepsis, hypoxic brain injury, non-HIE brain injury, ethnicity groups, COVID-19 status. Even in these potentially sensitive subgroups, no consistent benefit of conservative therapy was seen. Adherence and exposure. The conservative group did achieve significantly less oxygen exposure. Mean FiO₂, 0.31 versus 0.35. More hours in target. SpO₂ range, 63 versus 27 hours. However, 42% had periods of non-adherence, accounting for about 10% of ICU time, something common in real-world practice. Summary of trial findings. So, what did the UK-ROX trial teach us? Conservative oxygen therapy reduced oxygen exposure, but did not reduce mortality. Secondary outcomes were similar. The strategy appeared safe but not clearly beneficial. It challenges the idea that less oxygen is always better. Comparison with prior trials. These results are consistent with earlier trials like ICU-ROX and hot ICU, both of which also showed neutral outcomes. Some COVID-19 specific studies showed mild benefits, but evidence remains mixed. UK-ROX stands out for its size and real-world generalizability. Strengths of UK-ROX: massive sample size, 16,500 patients, excellent data completeness, primary outcome data was available for more than 99%, pragmatic design reflecting real ICU conditions, diverse patient population. Together, these make UK-ROX a landmark study in critical care. Limitations of UK-ROX. However, we must acknowledge the limitations. Open label design, possible performance bias, 42% non-adherence, dilutes intervention effect. Usual care group may have already practiced some conservative habits, not powered to detect rare adverse events, no standardized ventilation or weaning protocols. Clinical implications. The message is clear. We don't need to universally target SpO₂ of 88 to 92%. Most ICUs aiming for 94 to 96% are likely within a safe zone. Avoiding extreme hyperoxia remains important, but over-restricting oxygen offers no proven benefit. Could there be subgroups that still benefit? Possibly. For example, patients with brain injury, long-stay ICU patients, certain COVID-19 subsets. More targeted research is needed in these areas. Statistical versus clinical significance. Statistically, there was no mortality benefit. Clinically, no strong reason to change current practice. The confidence interval rules out any large benefit. So yes, the conservative strategy is safe, but probably unnecessary for most. Here's my summary of UK-ROX. Conservative oxygen therapy is not superior. Most ICUs already practice moderate oxygen targets. Chasing narrow SpO₂ ranges in all patients isn't helpful. Individualized, thoughtful oxygen delivery remains the best approach. We often say, less is more. But in critical care, less is sometimes just less. We need balance, not blind restriction. In the ICU, oxygen remains life-saving, but like all therapies, context and caution matter. Thank you for your attention. I welcome your questions and thoughts. Please, drop the comment in the comment section if you have any question on this topic.